Hi everyone, your Optum coach this side, and today we will be discussing the orbital walls. Now, as we all know, there are four orbital walls, and these are the roof, the floor, the medial wall, and the lateral wall. But before going into the details of each wall, I would like to remind you all that the orbit is formed by 7 bones, and these bones are the frontal bone, the ethmoid bone, the lacrimal bone, the maxilla, zygomatic bone, sphenoid bone, and palatine bone. So coming to the roof, also known as a superior wall or vault of the orbit, is concave triangular structure, and it comprises of 2 bones. These are the orbital plate of the frontal bone and the lesser wing of sphenoid, which is there posteriorly. So as we all remember, in the previous video we had discussed that the superior orbital margin is formed only by the frontal bone, whereas the roof is formed by the frontal bone and the lesser wing of sphenoid. Now coming to the features of the orbital roof. So there is a fossa for the lacrimal gland, which is a hollowed structure in the superiotemporal part of the orbit, which lodges the orbital part of the lacrimal gland. The lacrimal fossa lies behind the zygomatic process of the frontal bone in an anterolateral area. So this is the fossa, and it is usually quite smooth, but it may be pitted as shown in the picture by the attachments of the suspensory ligament of the lacrimal gland. The next feature is the trochlear fossa, also known as the fovea. It lies in the anteromedial aspect of the roof, medial to the supraorbital notch, 4 mm from the orbital margin, and is a site at which the trochlea, a small pulley, is attached. The tendon of the superior oblique passes through this trochlea. So to again remember, the lacrimal gland fossa is present in the anterolateral part and the trochlear fossa is present in the anteromedial part. The next feature is the supraorbital notch or foramen, which transmits the supraorbital vessels and supraorbital branch of the frontal nerve. And the next feature is the anterior and posterior ethmoidal canals. These are positioned at the junction of the roof and the medial wall above the frontoethmoidal suture. They transmit the anterior and posterior ethmoidal nerve and vessels. We'll be discussing this feature in detail in the next video of orbital fissures and foramens. Now coming to the relations of the roof is thin and translucent except at the area of the lesser wing of the sphenoid. It separates the orbit from the anterior cranial fossa and frontal lobes of the brain and meninges. The frontal bone forms the supraorbital and supratrochlear notches, which are transmit the nerves. Anteromedially, the roof is invaded by the frontal air sinus. Below the roof are periorbita, frontal nerve, LPS, that is levator palpebrae superioris, superior rectus, superior oblique, trochlear nerve, and the lacrimal gland. At the junction of the roof and medial wall are the posterior and anterior ethmoidal canals, which are here. At the junction of roof with the lateral wall is a gap posteriorly called the superior orbital fissure. The small area of lesser wing of sphenoid that is involved in this wall runs slightly downward, and an oval foramen, the optic canal, which is here, which opens as optic foramen, is located roughly at the apex of the orbit, which lies between the lesser wing of sphenoid and the body of the sphenoid. Now comes the clinical application of the roof, and these are: the superior wall is rather thin throughout its whole extent, and the periorbita can be peeled easily from its undersurface. A sharp object like a walking stick or umbrella, if introduced to the orbit through the upper lid, penetrates the roof and may damage the frontal lobe. On the cranial side, the dura can be lifted almost easily. Because the roof is perforated by neither major nerves or blood vessels, it can be easily nibbled away in transfrontal orbitotomy. In an elderly adult, bone in this area may resorb, leaving only a periosteal connective tissue in contact with the dural coverings of the frontal lobe of the brain. The next wall that we will be discussing is the floor of the orbit. The floor of the orbit is triangular in shape. It is shortest of all walls and comprises of 3 bones. These bones are orbital plate of the maxilla, which forms the medial part and the largest part, the orbital process of the palatine bone, which is here, which forms the smallest part, and the third bone is the orbital surface of the zygomatic bone, which forms the remaining part. Coming to the features of the orbital floor, the floor slopes slightly downward from medial wall to the lateral wall. The floor does not extend to the orbital apex, but instead ends at the pterygopalatine fossa, hence it is the shortest of all walls. Okay, so if this in the diagram, when we see, the floor does not extend to the full length, it ends before reaching the orbital apex, and hence it is the shortest of all walls. The floor is continuous with the lateral wall anteriorly, but is separated from it posteriorly by the inferior orbital fissure. So as we can see, this is the inferior orbital fissure, which is separating the floor from the lateral wall. Running forward from the inferior orbital fissure is the infraorbital groove, which runs in an anterior direction. As this groove nears the orbital margin, it descends inferiorly into a canal that exits the skull as the infraorbital foramen. We had discussed this in the previous video, that the orbital foramen lies 4 mm below the inferior orbital margin on the maxillary bone in line with the supraorbital foramen. So you can go back to the previous video and check it out. The infraorbital canal or foramen transmits the infraorbital nerve, which is a branch of maxillary division of the trigeminal, the infraorbital artery and the infraorbital vein. The vein connects with the inferior ophthalmic vein, connects the inferior ophthalmic vein to the facial vein. Now coming to the relations, below there is the orbital plate of maxilla, which is around 0.5 to 1 mm thick. It separates the orbital cavity from the maxillary sinus. It also forms the roof of the maxillary sinus. Above, it is related to the inferior rectus muscle, the inferior oblique muscle, and nerve to the inferior oblique. Coming to the clinical applications, the orbital floor, being quite thin, is commonly involved in blowout fractures. It is easily invaded by tumors of the maxillary antrum, as it forms the roof of the maxillary sinus. The floor of the orbit is best visualized with standard PA radiographs. The orbital floor can be approached easily by inferior orbitotomy, that is the antral approach. However, the utility of this approach is limited as only a small proportion of tumors are found in this area. Now the next wall that we will be discussing is the lateral wall. So lateral orbital wall is the thickest wall. Lateral wall diverges at an angle of 45 degrees from the sagittal plane and 90 degrees from the other lateral wall. The lateral wall of the orbit is triangular in shape and comprises of 2 bones, that is the zygomatic bone, which forms the anterior third and the orbital surface of the greater wing of sphenoid. So, zygomatic bone and the greater wing of sphenoid, which forms the posterior 2/3. Now, coming to the features of the lateral wall, the first feature is the spina recti lateralis, which is a small bony spine on the greater wing of the sphenoid near the apex of the orbit. So, this is the place, this is where it is, that is the posterior part of the lateral wall, which gives origin to part of the lateral rectus. Zygomatic foramen, which transmits the zygomatic nerve and vessels to the temporal fossa and cheek. So, there are two foramens, that is zygomatico temporal and the zygomatico-facial, which we will be discussing in the next video. The next feature is the lateral orbital tubercle, which forms the attachment of check ligament of lateral rectus, suspensory ligament also known as Lockwood's of the eye, superior transverse ligament also known as Wittnall's, and aponeurosis of the levator palpebris superioris. So, this is an MCQ which is asked frequently about what all is attached to the lateral orbital tubercle. The next feature is foramina for small vessels, veins that communicate with the middle cranial fossa. The lateral wall is posteriorly separated from the roof by the superior orbital fissure and from the floor by the inferior orbital fissure. As you can see, here is the superior orbital fissure and here is the inferior orbital fissure. Coming to the relations, laterally the lateral wall, that is zygoma, separates the orbit from temporal fossa interiorly and the middle cranial fossa posteriorly. We had discussed this in the first presentation, the introduction to the orbit. So, please go back there and get a better idea. Medially, its orbital surface is related to the lateral rectus, lacrimal nerve and vessels, zygomatic nerve, and communication between zygomatic and the lacrimal nerve. The roof is separated from the lateral wall in the back by superior orbital fissure and in front by the frontozygomatic and frontosphenoidal sutures. So, these are the sutures and the superior orbital fissure. The inferior orbital fissure separates the posterior part of floor from the lateral wall. The Wittnall's or lateral orbital tubercle lies posterior to the orbital margin on frontal process of the zygoma. The four structures attached to this eminence are the aponeurosis of LPS, the lateral palpebral ligament, the check ligament of the lateral rectus muscle, and the suspensory ligament of the eyeball. As I told you earlier, this is an important question. Coming to the clinical applications of the lateral wall, the lateral orbital rim is at the level of equator of the eye, allowing good peripheral vision. However, this also leaves the temporal aspect of the globe unprotected and vulnerable to trauma. The lateral orbital rim is thick and strong. The fractures of the lateral wall of the orbit are rare, although they may occur as a result of severe trauma, and it can be associated with the tripod fracture. The lateral wall covers only the posterior half of the eyeball. Therefore, palpation of the retrobulbar tumor is easier from this side. Because of its advantageous anatomical position, a surgical approach to the orbit by lateral orbitotomy is popular. However, the lateral rim of the orbit, which is forward extension of the lateral wall, is the strongest portion of the orbit and needs to be sawed open for this approach. The zygomatico-sphenoid suture is an important landmark creating the flap in Cronelin's operation and all its modifications. Once this bone flap has been turned, the surgeon has direct access to the superolateral, inferolateral and retrobulbar quadrants of the orbit. Since these quadrants are common sites for orbital tumors, the surgical anatomy of this area is important. Further, lateral wall is almost devoid of foramina, so its anterior portion can be broached without serious hemorrhages, as the zygomatic temporal vessels usually do not pose a problem. So the next wall and the last wall we'll be discussing is the medial wall. The medial orbital wall runs anterior-posteriorly and parallel to the sagittal plane. It is thinnest of all walls and its paper-like appearance is reflected in its name, that is lamina papyracea. So this is an MCQ point, that why is it called this? Because of its paper-like appearance. Now medial orbital wall comprises of 4 bones. These are frontal process of the maxilla, lacrimal bone, orbital plate of ethmoid, which forms the largest part of the medial wall, and the body of sphenoid. So these are the MLES. So this is the composition of the medial wall. Coming to the features of the medial wall is oblong in shape and is thin. As discussed before, it is the thinnest of all walls. The 4 bones that comprise these walls are separated by vertical sutures. Anteriorly, it contains the lacrimal groove, which is the bony housing of the lacrimal sac. This groove itself is formed from the lacrimal bone and the frontal process of the maxilla. It is bound by anterior and posterior lacrimal crests and is continuous below with the nasolacrimal canal. The nasolacrimal canal extends inferiorly from the lacrimal fossa on the medial wall and terminates in the inferior nasal meatus in the nasal cavity. So all these are MCQ points. So coming to the relations of the medial wall, the medial to this wall in an anterior to posterior sequence lie the anterior, middle and posterior ethmoidal air sinuses and the sphenoid sinuses. This is the thinnest of all walls and is largely transparent or semi-transparent. The ethmoidal air sinuses can be easily seen through this wall in a dried skull. Lacrimal sac along with its fascia lie in the lacrimal fossa. The orbital surface of the medial wall is related to the superior oblique muscle in the upper part near the roof and the medial rectus muscle in the middle part. In between these two muscles lie the anterior and posterior ethmoidal nerve, the infratrochlear nerve and the terminal branch of the ophthalmic artery. The floor is joined to the medial wall at the sutures connecting the bones of the 2 walls and the anterior and posterior ethmoidal foramen are located within the frontoethmoidal suture at the junction of the roof and the medial wall. So this is the suture and this is where the anterior and posterior ethmoidal foramen are located. The small pot of sphenoid bone present in this wall is a part of the body of sphenoid and is located at a posterior end adjacent to the wall of the optic canal. Just behind the posterior lacrimal crest, following structures have their attachments, and these are Horner's muscle, that is the lacrimal fibers of the orbicularis, septum orbitale and the check ligament of the medial rectus muscle. Coming to the clinical applications of the medial wall, the cribriform plate lies at the level of frontoethmoid suture. Excursion above this level during surgery on the medial wall would cause a cerebrospinal fluid leak. The thin lamina papyracea allows transmission of infection from the ethmoid sinus through the ethmoid foramen and ethmoid sinusitis is most commonly associated with orbital cellulitis, especially in children. Medial walls of the two orbits are parallel to each other and being thinnest are frequently fractured during injuries as well as during orbitotomy operations. The anterior ethmoidal foramen is 22 mm posterior to the anterior lacrimal crest. Posterior ethmoidal foramen is 12 mm behind the anterior ethmoidal foramen, and the optic canal is another 6 mm behind the posterior ethmoidal foramen. So, this 24-12-6 rule is useful while operating on the medial wall of the orbit. So, anterior ethmoidal foramen, posterior ethmoidal foramen, and the optic canal. So, there is a 24, 12 and 6 mm rule that you have to remember. The medial wall is frequently eroded by chronic inflammatory lesions as it is thin, cysts and neoplasm that originate in the adjacent air sinuses. During surgery along this wall, hemorrhage is most troublesome due to injury to the ethmoidal vessels. In addition, the medial palpebral, frontal and dorsal nasal arteries pass forward near the medial wall. The medial wall can be easily visualized on a routine PA radiograph of the orbit. For more videos, please subscribe to my channel and do let me know in comments if you want me to make any specific video. Thank you.